implemented. And yeah, as a context, we all know our health financing system has been marked by a lot of out-of-pocket expenditure in Nigeria. The system has also suffered a lot because we have limited budget allocation into this particular pocket. Health is one of the lowest budgets, and that's part of why, for people to access quality health care, they practically need to be out of pocket. So recently, the Honorable Coordinating Minister, as well as the health team, has done a lot of beautiful work on setting up the sector-wide approach and seeing how they will catalyze efforts to put together resources to reduce the out-of-pocket expenditure that are paid. So there are two things that are being done already. There is the basic education from 2.0, as well as the swap. For the basic education fund, is more of a strategic initiative aimed at achieving the Nigerian health goal by improving primary health care nationwide. And this is funded by at least 1% of the consolidated revenue and expected to receive about $2.5 billion between 2024 and 2026. For the sector-wide approach, it's been adopted as key policies to coordinate funding from various sources, including government, donors, and private health facilities, more like a basket where every stakeholder that are interested in getting good health to every citizen of the world to drop their fund, and that can be leveraged to catalyze health outcomes. So that's the overview of what Basic Healthcare Provision Fund and the sector-wide approach is aimed to achieve. So some facts we need to know about the Basic Healthcare Provision Fund is that it's aimed to prioritize regions based on heightened health needs, particularly those in rural areas with limited transport options and a higher incidence of high-risk pregnancies. There are plans to increase the enrollment of that to ensure that we have more facilities that can deliver the basic healthcare provision to everyone that visits an health facility and require healthcare. So there are two key actors for this, and most of the conversations today will be from seasoned professionals and industry leaders from those two agencies. We have the National Primary Healthcare Development Agency, who will be seeing the execution of this from the lens of the Primary Healthcare Gateway, as well as the National Health Insurance Authority, who will be seeing on expanding the coverage by ensuring that we have more numbers enrolled on the health insurance coverage in the country. There are other health financing policies, of course. There is a conditional cash transfer as well as vulnerable group fund that have been done. We felt this is a big topic, especially with the recent LG autonomy bill, which significantly must have a lot of impact on how we need to prioritize our health funding in Nigeria. The LG autonomy means the fund that typically go to the state governments, some now go to the LGAs, and that means the state government, for MOU, Memorandum of Understanding to deliver health, domicile at the state, there then need to be some key players at the LGA also pulling in resources to do this. At A Strategy and Consults, we have done a lot of work on health financing in the last few years, and we've identified some key problems that are basic gap that has limited the impact that all of this should be having. One is the delayed budget allocation and releases that has plagued how health outcomes should move better than it's moving currently. There are also weak institutional capacity for administration and monitoring. The coordination system is not very great, especially at the state-led health systems. And also, we also have some political interference in setting priorities at the subnational level. So I'm going to pause here as I'm not a professional in the room. So ladies and gentlemen, at this point, I will hand over the mic to the moderator, Dr. Nnennaya, Technical Advisor to the Director General of National Health Insurance Agency, to come and steer the conversation and help us dive into this topic to get all of the needed insight for us to move from where we are currently to where we desire to be in terms of health funding and attaining the universal health coverage that we all crave in Nigeria. Thank you everyone for listening to me. Over to Dr. Nnennaya.
Thank you. That was very succinct. And he has succeeded in giving us an overview of health financing strategies and policies in Nigeria. And we're going to be going into a panel discussion that will give us a deep dive into various perspectives. So it's my pleasure to now invite the panelists one by one to come and sit here on the podium and, throw more light on some of the issues that he has raised. Our first panelist is the Managing Partner and Program Director of DGI Consults. He's an experienced public health practitioner, program manager, very astute. He's well known for spearheading and participating in many health sector reform initiatives, including the Legislative Network for Universal Health Coverage and the UAC Forum. You cannot discuss political economy, equity for the vulnerable, and health sector reforms locally or internationally without him. Ladies and gentlemen, may I invite Dr. Gafar Alawode to come and join us. You're welcome. Take your seat. The next panelist is Dr. Fejiro Nwoko. She's the General Manager and CEO of the Nigeria Solidarity Support Fund, which is a non-governmental organization that strengthens resilience of healthcare systems. It also supports vulnerable groups and also the reskilling of Nigerian youths. She is a seasoned global health policy expert, but she's also passionate beyond policy development. She's also passionate about innovation and also about execution. Ladies and gentlemen, a warm round of applause for Fejiro Nwoko. So, in the spirit of equity, we have one man, one woman. Next person. Our next panelist is the Director of Special Duties at the National Primary Healthcare Development Agency. He's an astute public health physician. He's also an experienced program manager. And he has been the focal person for the Basic Healthcare Provision Fund for quite some time. Ladies and gentlemen, a warm welcome for Dr. Oritseweyimi Ogbe. Welcome, Dr. Ogbe. Please have your seat. One more panelist. Now we have quite a number of doctors. We want to invite a development expert and also the country director of budgets. Now, budget leverages creative technology to simplify information for the general public, right? So that stimulates us having a community of people who can advocate for what they want, advocate for reforms, and also hold the government and other stakeholders accountable. Ladies and gentlemen, please help me welcome Mr. Gabsyn Nokeowo. You're welcome. Right, so all our panelists are comfortable. I have your permission to join you and sit down. Very apt, Dr. Gafar is at the end here. I think we'll be starting with him and also with Dr. Ogbe as well. Right, so let's start. Dr. Ogbe, you saw the presentation and we're talking about the Basic Healthcare Provision Fund. And the two gateways were put up there, the NHIA and the NPHCDA. So from your experience, NPHCDA is one of the gateways. How is the NPHCDA going to leverage SWAP to ensure that it reaches those hard-to-reach communities, those vulnerable people in the communities? Can I have an extra microphone, please?
Thank you very much for the opportunity, and good morning to our esteemed, very young audience. It's really a pleasure to be here to address the cross-section of Nigerians other than the usual technical sessions that we have. So I think it's important, looking at the audience, to just give a synopsis of what the basic health provision is to start with. So one of the things that the government tries to do is ensure that Nigerians can receive health as a right. But even if you have it as a right, if there's no active measure to make that right happen, then it's just a right you have, a right to say about, but you have no access to exploring your rights. So one of the things that was done in the National Health Act of 2014 was that the federal government of Nigeria established what is called the Basic Healthcare Provision Fund. So this fund, it's money that comes from the federal government's account, and this fund is dedicated primarily to primary health care to be like a catalyst to jumpstart a lot of things. So the fund basically does two big things. One, it sends money for people to be covered, so that when they are ill and go to seek care, they don't have to pay. That's the health insurance. And this happens through the National Health Insurance Authority and also the state health insurance agencies. It also sends money to primary healthcare facilities through the state primary healthcare boards, so that they can actually provide money to primary healthcare centers to be able to prepare themselves and have operational costs to provide services. So they can use that money to buy medicines, they can use that money to fix their generators and provide power. They can use that money to buy commodities they need. They can use that money to travel to locations where people are underserved to provide services, and importantly to collect percents and make sure it's administered to Nigerians. So that's a synopsis of what the basic healthcare provision fund is. And it's a law in Nigeria, and if you Google it, you will see, you will learn more about that. So how are we leveraging SWOP? So SWOP is something that we have always, as government, wanted to do, but never been able to get the political will to do. But with the coming of the new administration, with the President Bola Ahmed Tinubu, he made a commitment to health and said, these are the targets I want to achieve during my tenure in health. And he appointed a coordinating minister of health and social welfare. And that the idea of that was to see that health is not just happening alone, but it's also inclusive. And most times, things that have to do with inclusiveness are considered like social welfare things. Making sure women are inclusive, making sure youths are inclusive, making sure that people that have various sorts of disabilities or inequities are inclusive. So he's the coordinating minister, so has that purview. So in trying to make the president's commitment come true, he said, you know, we can do it if we have a single plan that everybody working within the sector, be it government, be it national, be it state, be it partners, be it donors, be it consultants, be it pressure groups, advocacy groups. We must have one plan, and then everybody can use their resources to implement that plan. That is what the SWOP is all about. It's what the sector-wide approach. So everybody within the sector agrees on what is the most important thing we must address, and then everybody that has resources targets their resources to addressing that. Does not mean everybody puts all the money in one bank account, but everybody is just working towards the same goal. So in doing that, that is how we are trying to ensure that we actually address the poorest population. Because first, monies that have gone in different directions doing likely the same thing is all now viewed as one goal and targeted to the priority. And for that to happen, based on presidential commitment, the SWOP is being implemented through a strategy we call the Nigerian Health Sector Renewal Investment Initiative. So this initiative, the word investment is important, because even though we know health is a right, most times nobody's paying attention to actually invest in health. Hence that word is there. So with all the funds in the right pool, and the key word in that strategy, if you Google and see it, you'll see it's written on top there, to save lives and reduce pain from health-related conditions. And who are those that feel it the most? Is the most vulnerable, right? That is why that is really important. So the fund is together, we can target the vulnerable. We have one plan that prioritizes saving lives and reducing pain, which targets the most vulnerable. And the most vulnerable that we now use a lot of data evidence to take decisions. So not just that, oh, we have money, people are ill, who can treat them. If we look at the data, where's the illnesses more? Where do they need the most intervention? What are the interventions required there? And that is used to do that. And because of that, one of the main things we're doing around of now, I have to give that kind of background looking at our audience so that they can follow the conversation. So please apologize for taking an extra minute. One of the main things we've even done is that, because part of the strategy at the primary care level, which is managed by the MPCA, is now to make sure we revitalize primary care centers and make them function. So we've taken that baseline of the centers that receive money from the basic care provision fund. We now know their status, and we're working with the states that have the bulk of the money for revitalization to make sure that the right center that requires the right intervention is what is getting to. We're using data in that way, right? And we're also ensuring now, because of the SWOP, that there's some transparency in who has money, where is the money, and what the money is being used for. Even our partners, because before now we wouldn't know where the money is and where it's going. But now even government has to tell the partners have to tell the government this is the money we have. So that transparency is improving the investment. But more importantly is the insurance, which is happening through the National Health Insurance Scheme that is being expanded on that SWOP, because there are more resources coming in to cover what we call it, cover lives and all of that. And the money that is coming from the BSF to the facility, all that is being used to ensure we improve quality of care and that we reach the reachable. So I'll just pause there for now. Thank you.
Thank you so much, Dr. Ogbe, for that overview. I'm sure a lot of our audiences now, they understand swap better. And you mentioned something about the BSCPF, the MPCDA gateway, also leveraging the swap to revitalize the primary healthcare centers and identifying those who are really vulnerable so we can focus on them. But Dr. Gafar, let me quickly ask you, with all this money that we are going to get from various partners, donors, government, and everything in one basket, how are we going to ensure equity and efficiency in the utilization of those funds?
Okay, thank you very much, Nina, and good morning, everyone. And first and foremost, let me thank and congratulate the organizer of this very important event for the job well done. Gender and inclusion is very central to achieving universal coverage, which some of us are very passionate about. Before answering the question of efficiency, equity asked by Nina, I think it's very important to set the stage and to acquaint us with where we are in the global sphere with regards to universal health coverage. We have a lot to do, and if we look at the most important indicator used to gauge mileage of universal health coverage, we call it a universal coverage index, which is a global index given a score to each country. Nigerian score out of possible maximum of 100 is only 38 in terms of universal coverage index. But if you look at sub-Saharan Africa, of a group of very poor countries, their average is almost 50, sub-Saharan Africa. Now, while one of the most major reasons why we are actually not made progress is because our health system delivery is not inclusive enough. It's leaving behind the poor and the vulnerable people, which is very, very, very important because in Nigeria, it shows that if you have money, you have access to almost any type of care you have. But if you don't, you're actually deprived. So that sets the stage in terms of where we are in the sphere of things generally. So with regards to how do we ensure efficiency, how we ensure equity, there are two big questions. And I would like to start with the efficiency part of it. Nigerian health system is highly inefficient, and if you look at across parameters, and I will give you an example. If you look at human resources for health, and I'm using human resources for health because that is where the bulk of money on health is actually going to, government money. An average state in Nigeria spends almost 70% of health spending on human resources for health. And this is where we have a lot of inefficiency, like I talked about, a lot of issues around ghost workers, around a lot of absenteeism, to the extent that there is even a phenomenon called organized absenteeism now, where in a particular facility there are 58 workers. Maybe there will be an arrangement, only 2 will be working, the rest will be away for next week. So we are wasting a lot of money in all aspects. I'm just using human resources. In terms of productivity, a survey done in Africa shows that an average health worker in Nigeria is far less productive. Maybe sees an average of 3 or 4 patients. Of course, it varies from facility to, but it's average. And when you see a country like Tanzania, they see more than 12 and all those. So there are a lot of ways where we waste our resources in the health sector, and even putting a health facility where they are not needed, and where they are needed, they are not there, and all those stuff. Maybe prescription for non-prescription generic drugs, which is to be cheaper and save us money and everything like that. And then the issue of equity, of course, is well established in terms of who is able to receive care. So it's well established that an average, if you look at the wealth quantile in Nigeria, the richest class, they are 5 times likely, they are women there, likely to deliver in health facility than the poor woman in Nigeria. But maybe enough of lamentation, let's open the book of a solution. So in terms of what could be done, I think Dr. Ogbe has spoke to some of them. In terms of leveraging SWAP as much as possible, SWAP provide opportunities to ensure coordination so that there's reduce the overlap in spending and all those stuff like that, to strengthen coordination as much as possible. But at the same time, we need to put systems in place to ensure we are tracking resources. I'm happy budget is here. They have been doing a lot of great work in terms of following the money, ensuring we're able to track what the money is spent on. But at the same time, we need to leverage technology. There is an example of Gombe State where they have introduced biometric attendance tracking, where they have been able to discover a lot of ghost workers. They've been able to discover those that are not ghosts, that are not working in the states. They've discovered that those that will come and go and all this stuff like that. So we need to deploy technology. Another area which is important, we have to look at, we have seen an example in Lagos State. Lagos is doing what they call, the governor has given a standing order for exit replacement of existing workers. We know this is the era of Japa syndrome, where people are leaving. But the unfortunate thing about Japa is that apart from creating gap in service delivery, there's also a room for a lot of wastages as well. Do you know that when people leave, when they die and all those stuff, the money is still leaving the cover of the government? So what the governor has done is that, and you know the bureaucratic challenges around recruitment, what the governor has done is to ensure that there is a standing order for replacement. Any health worker that leaves today must be replaced time. So coming back to the equity, I think there are a number of existing policy trusts as well. Dr. Ogbe talked about basic care provision fund. But at the state level, almost all the states in Nigeria, they have state health insurance legal framework that actually introduces like 1%, that mirrors what's happening at the national level, introducing 1% basic care provision fund. At the last count, maybe less than 10 states actually funding this basic care equity fund. So we have a role to play, all of us as civil society, to track who is releasing the money, but it's not enough for the money to be released. We have to track to ensure that it is actually those that need the money that are benefiting from the equity fund. So one ideal thing to do is to go and look at the social register and identify who are the poor and vulnerable, and select them, enroll them. But the social register itself, there are a lot of challenges as well. Somebody was telling me in the social register in the States, they found the name of the mother of the Speaker of the House of Assembly, and I'm wondering how vulnerable that one could be. So we have to look at that as well in terms of equity. But before I go on this issue of equity, if you look at amount of money available today, basic care provision fund, equity fund, put everything together, and considering the size of the poor and the vulnerable, it's like I won't call it a drop in the ocean, but we still have a long way to go. So people are talking about how do we mobilize funds from like innovative resources. A lot of analysis have been done. I think we just want to ensure there's a political will to pursue those innovative resources that will mobilize additional funds, and we ensure these funds are actually going to people, and we are tracking, doing benefit incidence analysis to know who's benefit. I would like to pause here for now. Thank you.
Thank you so much, Dr. Gafar. Thank you. And as he was listing all this, he was also giving us some solutions, which brings me to budget. I mean, Dr. Gafar mentioned tracking the money. How do you plan to evaluate swap? How do we know it's working? How are you going to track the money and make sure it gets to affect the lives of the common man on the streets? Let's hear from you.
Thank you very much. Good morning, everyone. And I think Dr. Gafar has done a bit of justice to that topic. And when we talk about effectiveness, I think the key point that we'll have to pay attention to is data. And I mean, we work with data, and data they say don't lie, right? Particularly when we talk about the marginalized group, there is an increasing demand for us to be able to have an accurate record of who are the marginalized in our population, who are those that fall into this group. I mean, there's an instance that Dr. Gafar mentioned of, when you have opportunity to look at the register. I mean, we have also seen the register. Sometimes you just try to Google some names, find some names, and you are seeing some names, and you are asking yourself, are these really the people that really need professional cash transfer or
Okay.
All right. Yeah, I think there's later. Yes. So data is very important for us to be able to understand the number and the that we are dealing with when we are talking about marginalized group. Then beyond that is also having an assessment of what are the needs of this group, and understanding that when different states in Nigeria have different contexts, even within the states there are different contexts within local government, within communities. How are we ensuring that in the distribution of resources, the available PHCs, a so to say metropolitan city within a state, that if you put the same level of resources in that PHC as well as you put in a PHC that is in a rural community, the number of needs that they are attending to is quite different, right? In this PHC that is in a metropolitan city, it's such that the majority of the people there can afford the services. They can even afford to go to a private healthcare. And then when you go to a PHC that is in a rural community, you find that particular PHC attending to quite a number of people that fall within the bracket of a marginalized group. And then the unequal distribution of resources then affects the effectiveness of SWAP and what we are trying to achieve. So I would say baseline is very important, but beyond baseline is that we need to embrace the involvement, inclusion of the marginalized group themselves in this process, right? Because involving them then make it easy to, number one, market the initiative, market the ideas of government. If someone has gone to a facility and they have been well attended to, there is more likelihood for that person to be able to preach and inform another person that cannot afford that service to go to a particular healthcare center. And this is what we are saying. We have the privilege of working, in the grassroots community, and we have seen that works out where once there is a sort of improvement in service delivery, people in the community tend to tell themselves, right? And what we are seeing in SWAP is beautiful. Dr. Ogbe, narrated it. It's beautiful. We need to start, even talking about data, we also need to start from who is doing what, where is the central plan. And in all of this, we will not do away with technology. Technology will allow us to be able to see the overall goal that we want to achieve as a nation, will help us to see who is doing what where, and then will help us to be able to hold ourselves accountable. And not just government, holding government accountable now. There are private sector, there are development partners, there are civil society organizations, there are different entities that is contributing to the overall SWAP agenda. When we have it well spelled out in a publicly accessible domain, it helps us to know who is contributing what, who is meant to do what, right? And by so doing, we'll be able to hold ourselves accountable and effectiveness will improve.
It's a round of applause for him. So I hear lots of things. I hear data is key. We must leverage technology. We must also involve the marginalized groups because we can't do anything for them without them. And again, I'm also hearing that we need to break down this swap and know who is supposed to do what and how much is coming in and what is that money going to be used for so that we can track it. Thank you so much. And that brings me, CCT has been mentioned, getting money across to these people that are marginalized. So my question goes to Fejiro. Controlled cash, this conditional cash transfer, thank you. Conditional cash transfers. We've talked about the social register, yet there are so many problems with it, yet we know it has been used for conditional cash transfers. In your own estimation or your experience, has it been successful so far? If not, what are the challenges and how do we move forward? Thank you for that question. Good morning, everyone.
Okay, so just set a context and define conditional cash transfer because of the audience, just following the cue from my other panelists. It's a program where health behavior or health-seeking behavior is rewarded by financial incentives. So different countries have used it, have tested it to improve the health outcomes in the country. There are case studies of countries like Brazil, Mexico, where programs have been initiated with this CCT as a model for the program. And they saw really good data on like the uptake of vaccines, so vaccination rate, reduction of malnutrition, and then increase of family planning usage and overall health utilization. Even in Nigeria, I know that there is the National Social Safety Net has a program where they have that conditional cash transfer, and studies have shown a 30% increment in ANC visits where that has been instituted. So, my co-panelist said, data doesn't lie. So it means that there is a use for CCT. There is a use for it at an early stage, so a short-term project, a short-term implementation, a short-term method for a long-term gain. However, with everything that has pros, it has the cons. So you've mentioned one rightfully, which is who are the target audience. So if we're using this Nigeria social register, we should start from there. Is there targeting? Are we really targeting the vulnerable group? How can we make the social register smarter? And there are several ways. All of us, the majority of us have registered for our national ID cards. Majority of us have BVN. So there are ways to synchronize data in Nigeria and to come up with a social register that would definitely target the vulnerable. So the first thing is really, can CCT be disposed or used for the target group, which is meant for, which is the vulnerable group. Secondly is the monitoring. So targeting first on the group, also targeting for the health behavior. So CCT must have a targeted health intervention. It cannot just be left broad, it must be very specific. So it's specific, such as the ANC visits, very specific reward for specific intervention. Secondly is monitoring. We have to monitor, like you said, who got the disbursement and how, and was it just someone ticking? Because we have, from a program implementation part, we know that data doesn't always lie, but data can lie because somebody else is collecting the data. A human being that has flaws is collecting the data. So there must be monitoring, external monitoring. There is also the part where CCT must have a long-term complementary service, which is health education, so that you can bring them in with financial incentives, but the culture of financial incentives would get to its peak and it will die down. So after a while, people are going to throw your money back at you, or they're going to ask for more money, or they're going to ask for more, and you can't keep giving more and more. So from the very onset, what are the complementary services that will go with CCT? Such as health and education. Another thing is also research, because most times we always talking to the beneficiaries and not listening from their point of view what is causing the poor health seeking behavior. And secondly, another complementary service that we must have for CCT is that...
Hi everyone, good morning. My question is, how can AI be leveraged to close the gender gap in various industries? So I know that we've been talking about AI, to close the gender gap.
Tech team, please, can you? Okay, thank you, please.
Thank you. So another complementary service we must have is a complementary service where we also reward the health workers. Because if we're just rewarding healthy behavior, so that's the performance-based financing. If we're only rewarding, we know that the health workers will frustrate the program. So there is always the supply and the demand side. Another thing is also the quality of care. Most people don't see, you will not buy what you don't want, what you don't need. You only buy what you need, and yet we know that people drink Coke every day. Not because they know that they need Coke, even when they know that, sorry if I'm reducing any brand, even when they know that fizzy drink has a lot of sugar, they buy it. Why? Because they have been branded to see that they need it. So if health has not been branded to see that they need it, so we did a research sometime on, with our youth campaign, and they said even for things like HIV, that connotation where HIV doesn't have cure is a deterrent to screening. That can't be branded. So we are not branding health in a way that is encouraging for anyone, so that when that city wins, when it gets to the peak, when it's in a decline, we can lay on that. And lastly, what I would say to that is that we must have quality service delivery. The patient comes even after giving money and they lose their baby in delivery, they won't come again.
Thank you so much. A round of applause for her, please. The CCTs, they are effective. She says they're better in the short term. We should focus on targeting. We should focus on targeting as well. So we've had some of the challenges and some of the benefits. Dr. Gafar, very quickly, should we be thinking of scaling up CCTs? What is your opinion?
Okay, thank you very much. I think, again, before answering that question, don't let us forget that conditional cash transfer is a vehicle for delivering resources to buy services. And there are other vehicles as well, there are health insurance and all those stuff. I think what is important is to look at the source of the money in terms of the volume of the resources and the sustainability of that. If it is a public money that will be there for a long time and all those stuff that is financing CCT, fine. But the challenge here is that one donor, World Bank here and all those stuff like that, put this money there for CCT, 3 years, the money dried up and all those stuff like that. So, like my colleague here said, in principle, CCT make a lot of sense. They have seen a lot of results, even locally, where it has been delivered and used to upscale services. My challenge is that what is the sustainability of the source of the funding that we are using? Secondly, the second aspect is it's not only about having the money to buy the services, but there is this strategic purchasing element where you link money to services and the quality of services as well. Do we have the optimum mechanism within the CCT to be able to actually do the strategic purchasing where we are looking at the quality of service being delivered? I think in terms of scaling, my recommendation is that, of course, we can scale it as work and everything. But in the long term, I think we should be looking at long-term mechanism of integrating this money into the health insurance as much as possible. Don't forget that most of the conditional cash transfer that you have, or the one that's not even conditional, people end up, look at most of the social investment transfer and everything. People eventually use the bulk of the money to access healthcare. So why can't we, in the long term, integrate the health insurance and learn from some of the important lessons learned from CCT to modify how we design?
Thank you very much, Dr. Gafar. Thank you. We're moving faster because of time. Quickly back to Mr. Biyo here. Your question is, corruption is something that is multifaceted. We see it all over. And I'm sure the health sector is not immune. So what can we do about it from your perspective?
All right. I mean, tackling corruption will come back to the conversation around transparency and accountability. And I make a distinction between the two. Transparency is that there must be a process, a system that shows what goes in and what goes out and how, by who. Accountability in the sense that entities responsible for managing resources must be ready to answer questions. If we are not ready to answer questions, there is no point being transparent in the first place. And when it comes to, we are playing very low when it comes to how much we need to invest in our health sector. So the little that we are investing, we must be able to create a system that makes it open, right? And to do that, it's simple. We have some programs that have worked in Nigeria before. One of it is what we call the State Fiscal Transparency and Accountability that was led by, it was the World Bank project to states, and it was a disbursement-linked indicator, right? There are set of indicators that states or entities that are managing our resources need to meet before a new tranche of disbursement is given to them. I think for the health sector, considering the dire need that we have, the very scarce resources that we are dealing with, we may need to work with a system like that. A system where before a new disbursement is released to the states, there are key indicators of transparency, documents, disclosures that they have to do to qualify for the next one. And then, in dealing with corruption also, we must involve the people. We must involve the people, particularly when we are talking about SWOP, we are talking about the Vulnerable Group Fund, right? We must involve them. And the systems are there, right? We have the WC system that government has already, facilitated in practically all the communities in Nigeria. Can we get them involved in the planning, in the reporting, so that, so that the community see what is going on, they put their signature to it, and then let it be on them too, that maybe they are also abating corruption to try in their community and undermine the efforts of government. But if we put all of these systems in place, maybe we'll be able to move the needle a bit forward.
Thank you so much. Please a round of applause for him. Thank you. Dr. Ogbe, we're going to be keeping it brief so that you have opportunity to take some questions if possible. How does MPACDA plan to really target the informal sector? We had something about targeting. How do we really want to focus and make sure that these primary healthcare services are available for people in the informal sector, a lot of whom are vulnerable? Briefly, yes.
Thank you very much for that. I think the informal sector are really those who are not like having 8 to 4 jobs or 9 to 5 jobs that are insured by their employers or by government to work for the public service. These are people who do their own business or employed, and they also need to be targeted. And most times in health, we actually consider more of the vulnerable groups in terms of those with, that are affected by poverty in a multidimensional way. So one of the things we really are doing there really are 3 key foods. One is that we are revitalizing primary healthcare centers, ensuring that where we have the most vulnerable people, the highest population are targeted, right? So that's one of the things. And working with the NHI, is also operating what they call the Vulnerable Group Fund. Now, this is a fund that's supposed to use things like the social register, which has just been talked about, but needs to be improved to actually see that the right people actually are the ones that are covered, and when they need care, they don't have to pay for it. So that's what the insurance coverage actually does. So the other way is also through the working with the state insurance schemes and other and community-based organizations. We have community health insurance schemes where people can come together in the community and either through the state insurance or their own create a pool and pay some money on a routine basis, which becomes their premium, and now register with the facility and pay money so that they can have care. So the basic health prevention fund, particularly when it comes to the one where you actually form more inclusive and better into 2.3, is actually looking at how the vulnerable fund can be upscaled. But this requires more investment, so more money has to be spent to see that people are covered. Another thing that is being done, which will be of real interest to the audience, is really digitalization. So there's a big movement to digitalize health in Nigeria right now, inclusive of how people enroll for their insurance, how they get information about health, how they find where their facilities are, how they complain and bring back feedback from the community to those that are applying. And that's also a room where the young persons that are into tech can begin to explore what are really the needs in health and how can we really target in that space. Because as opposed to more digital, there's more opportunity to interact and be inclusive, particularly for the young people. Particularly one last thing we're also doing that is important to the audience, in coverage of services that are now under insurance, particularly in the health sector, which the bulk of it actually are persons because most of them are employed and largely uncovered, which are things we need to really look into, is the fact that we're also ensuring that there are a lot more coverage for sexual and reproductive health issues. Because as young people, one of the challenges we have that are affecting more in the psychological fashion is when you have sexual and reproductive health issues. So we're taking effort of ways to control that this is more inclusive, and more of those services are covered. We're going to train people that's going to provide those services in confidential manner. And that, I think, will really target young people, making it exclusive, not just for the vulnerable, but poverty to actually benefit for the DSP to.
Thank you. Thank you very much, Dr. So quickly to Fejiro now. Let me quickly ask you, what is the role of the organized private sector? We talked about technology, digitization, financing. What can the private sector do to help?
Okay, thank you. The private sector would definitely have a complementary input to what is happening in the health financing space. We know that the government is still the largest funder for health. We can't take away from that. But there is a role for the private sector. One is in the and the resources that they have. The private sector has expertise. They have resources in terms of health facility. They have resources in terms of healthcare worker. They have the expertise in terms of both the healthcare machines and all of that. The private sector can contribute that to the existing insurance scheme. So then this calls for public-private partnership, which the Lagos State has done really well, especially in the area of implementation, and not just funding or not just bringing funds, but an implementation of this health insurance. We know that one way that health insurance succeeds is in pooling of funds and not fragmentizing funds. And that's my worry with the several pockets of insurance in Nigeria. It's that if we pool enough funds, we would address more people. Secondly, is that the private sector can also contribute funds. However, little compared to the government, they can contribute funds because first they have a CSR budget that they have regularly for vulnerable people. They can invest into health investment funds, which would target the vulnerable people. They can also sponsor workers that are working under them in health insurance scheme and add to the pool. So there is the financial hit for it. But we must make sure that we are complementing each other. We are not working in silos because then our target audience that will benefit, our beneficiary will be very little and we would not be able to sustain it over time. So I would love to hear from the NPCD what the plan is to roll out this PPP and work nationwide, and like Lagos State is doing.
Thank you so much. I'm sure we'll facilitate that conversation. Please a round of applause for our panelists. So because of time, I think we can take just one or two questions briefly before we wrap up. Any questions? And there's one hand up, okay, and two. Just take two. Very briefly, please. The tech team, if we have extra microphones that we can. 1 minute.
All right, thank you very much for that. My question is really around equity versus efficiency. We know that there is limited resources. Right? So how do we balance trying to improve access and also knowing that we have...
Thank you. How do we balance improved access, equity for the vulnerable population, just knowing that we have limited resources at hand to actually scale these interventions that we're talking about?
Thank you. Thank you. How do we make it go around and we'll still focus on the vulnerable? Dr. Gafar, I believe that's your question. Let's take all the questions together.
Good morning, everyone. My name is Rhoda Robinson, and I have just two questions. One for Dr. Fejiro. The first is you have talked about private sector engagement. Now, how do we go about building a business case for private sectors to invest in health insurance? Because one, health insurance for private sector is a business. Now we are looking at them turning this into a CSR, which is different from what they already do. Now, how do we ensure that they understand the final bottom line for building a business case for insurance? Then my second question is on the swap. And as a partner for numerous different states where we work on health, my organization works with different states on digital inclusion for healthcare and different health, over 100 facilities across, primary health facilities across different states. Now, how do we key into this, given the fact that we are in numerous states, and if we are partnering with this state and we are avoiding a duplication of efforts across the state, because different states have the different needs that we meet at the different times. Thank you.
Thank you so much. There is a hand up, two more hands, but I do not think we can take it because of the time. You can still meet the panelists later, please. My apologies. I believe two questions, one for Dr. Gafar, one for Fejiro. Dr. Gafar, please, 1 minute.
Okay, thank you very much. So with regards to the question around equity algorithm, let me provide the context. So the last time we were told that more than 100 million Nigerians are multidimensionally poor, right? And if we have to go by poverty alone, these are the people that cannot afford health insurance themselves, and they find it difficult to pay for health out of pocket. Now, if we look at the Basic Care Provision Fund, last time I checked, and Dr. Ogbe can correct me, maybe less than 2 million Nigerians are in the pool. So more than 100 million that are needed, we have money to cover only like 2 million. So I think the big question is that how do we mobilize additional resources? It's very, very important. No matter what is the equity in 2 million, 100 million people need is only money for 2 million. So I think the big issue here is that raising additional money from various innovative money sources. And I hope at the swap, we provide opportunity for partners to contribute as well, to put more money in the pool. We should not be depending on donor money. That's the truth of Nigeria. I'm saying this because I'm in Nigeria. But at the same time, if there's opportunity to mobilize our resources, we should. So I think there should be great effort around how do we mobilize money from the state, from the national, even from the local government, constituting local government financial autonomy to be able to do this. I think it's going to be very, very important. But what goes with that is the efficiency of managing even the little resources that we have. So we have to identify sources of leakages and try as much as possible to measure in place to block them. Thank you.
Thank you so much, Dr. Gafar.
To the question, so private sector involves all the private organization and not just private health insurance spend. So when I talked about the CSR budget, I was talking about private organizations that are not public that can contribute to health insurance. But to your question of private health insurance organization, how can they come in when they are for profit? I look at it as the way the banking sector, the financial sector works now, vis-a-vis how they worked some 10, 15 years ago, where we had so many banks and split across the country and having various number of clients that they were dealing with. And then we had the CBN come and collapse them into based on their capital. I think we need to do that for private health insurance. We need to, the government has to raise their capital to the point we force them to merge, because again, health insurance is about pooling of funds. It's about pooling, and we have a very young demography in Nigeria, so it's actually beneficial. So we will be able to save more money. We don't have an aging population, so the dependence on insurance would not be too negative for us if we have everyone in the pool. So I think it's for the government or the agency to raise the capital such that it will force smaller health insurance organizations to merge, and then they'll have a larger pool. And when there is competition, price would reduce. There could also be a play of combining resources with government, but I know that there's a lot of issue with that, where they can then cross-cuttingly either share resources with government for vulnerable population, so a percentage of the number of clients you have, you give that to vulnerable under the government scheme. How that can be worked together. But the first thing I feel like we need to do with the health insurance is to force measures to happen.
So thank you so much. That's market efficiency, commingling of funds. Thank you. Dr. Ogbe.
So very quickly on the question about swap, I think essentially, if you're an organization that works in various states supporting the health sector, if you have a national office, they can engage with the Federal Ministry of Health as a swap coordinating office, just a letter to the Honorable Minister attention, swap coordinator, the letter gets pulled into the whole conversation. But if you're just working with the states are just in the process of completing their annual plans. And in this, they're also mapping all the partners working with them. So just ask the states that how far they go with their annual plan, and if you have been captured as part of those working with them. Once you're captured, then automatically you're in the swap pool, because you're going to be reporting on your activities and what resources you're investing in the state, and that will be viewed at the national level. Thank you.
Thank you. So maybe Dr. Ogbe, just take your final word. Just give us 1 or 2 words, your final thoughts, way forward.
The way forward is for us relying more on digitization and data. Data is the one that minds all the information we will make and all the decisions we will take to see that the vulnerable are actually targeted and benefit the most from what mandatory resources we have. Thank you.
Thank you. Fejiro.
The last words would be that the world is evolving. Innovation is key. What happened, programs we initiated 2 years ago is not sufficient to solve the problem of today. Innovation with human-centered design is what we need to move the target for health insurance.
Thank you. Gafar?
Okay, thank you very much. So, to me, I think in addition to the important point on the ground, I think we're trying to solve Nigerian health system problem. It's very, very important to understand the whole, while fixing the part of it, and mobilize those that can help us to fix the rest of it.
Thank you.
Yes, my parting word will be on the people. As much as we are looking at innovative way of improving resources, increasing resources, we must create a system that also takes feedback from the people. We need to ensure that resources is matching with quality of service delivery. So let's create a system that collects feedback from the people and a system that works on those feedback to improve quality of care. Thank you very much.
Thank you. So parting words of our analysis, data, digitalization, innovation, a holistic approach, and focusing on the people and getting their feedback. So ladies and gentlemen, I want to thank you so much for being such a wonderful audience, and please give our panelists a wonderful round of applause for broadening our perspective and sharing their insights. Thank you so much. I think we can just take a group picture before we go down. Thank you so much.